Well, thank you, Morgan. That was absolutely lovely. And I hope everybody's feeling nice and relaxed and ready for tonight's um, talk. And it's going to be amazing. Today's event is Telehealth Lessons Learned. And so some of you have been here last year at this time. We did a telehealth, what's the future going to be? And now we're going to look back and look forward. And I hope you really enjoy the evening. I just want to remind you to sign up for Poll Everywhere because we're going to be doing some polls. There's a QR code right there and a link. And so you can be ready for that. And also, please introduce yourselves in the chat, who you are, what professional identity you have at the current moment, and anything else you would like to tell us. Next. So these are our hosts for the evening, and I'm very excited to introduce Nan Solomons, who is the director of the Center for Excellence in Digital Health. Welcome, Nan. And also Sue Gorin, who is an adjunct faculty in the School of Nursing and Population Health, and a very impressive telehealth consultant. I also want to mention that we have a wonderful panel a little later in the program who will be talking about their lived experience doing telehealth over this last year and now into the future. Next. So these are our learning objectives for tonight. We're going to provide an update on the current state of telehealth practice, and we'll hear that live from our panel a little later on. We'll describe how telehealth practice delivery benefits and challenges communication with both patients and clients and colleagues, and we're going to have you situate yourselves in each of those roles. We'll discuss how telehealth is or is not used to promote teamwork and telecollaborative practice, and examine ways in which telehealth practice engages patient-centered practice. And then finally, we're going to explore current and future integration of telehealth practices in relation to best practice delivery. Next. And so now I'm going to pass this on to Sue Gorin.
Well, thank you very much. And good evening, everybody. So it was just about a year ago when we last met. And at that time, we all had our fingers crossed that we had pretty much figured out how we were going to manage COVID-19. It was a very exciting time for telemedicine and telehealth, because prior to COVID-19, only about 10% of healthcare providers had ever used telehealth before or were the least bit familiar. But certainly as we went into 2020, particularly in March and April, telehealth became the only way to safely communicate with patients. And so since the 2020 pandemic, when we look at data today, 70 to almost 85% in some of the surveys I've seen of providers have now used telehealth as an opportunity to stay safe, but still manage patient care. So we're going to talk about that. Next slide, please. So here we are a year later, and we're in the latest wave of COVID. And so everybody is asking, well, what's going to happen? We certainly saw the huge spike in the use of telehealth when we ran into the pandemic. And then we saw it begin to drop off a bit. But even as it dropped off, the levels of use of telehealth were far superior to what they were prior to 2019. And we've seen it wax and wane throughout the last year. And we do see a downward trend, still far above what we were prior to the pandemic. But with all of the confusion about regulations and what's going to happen at the end of the year or when the pandemic is officially over. And so it's unclear exactly where we're going forward from here, but it is exactly why we're all here together tonight to talk about that. So next slide, please. Nan.
Yes, thank you, Sue. Great introduction to all of this. telehealth is big, and it's very hard to wrap your arm around what it is. It's patient, client, patient and provider care. It's also education. You could use it for telemonitoring. For example, checking in on a tablet that you took your medication today, or you went for a walk, or you practiced your breathing. Med management, again, same kind of thing. Maybe you have one of those fancy pill boxes that will ding when you're supposed to take your medication. It supports team-based care, as you see up at the right. Everyone can be a square on the screen and really talk about the patient in real time, rather than having the patient go from provider to provider and not really having them all talk together about what makes sense. Next slide. I don't know how many of you have heard of Everett Rogers and his diffusion of innovation theory. You might know him a little bit through Malcolm Gladwell if you read The Tipping Point. But essentially, people with something new, an innovation is something new to them. There are some people who get it right off the bat. So Apple announces a new phone and they are the first to sign up. Maybe a new pair of sneakers come out and they're the first in line and waiting for days to get them. So the innovators are the first people who might get something. And then there are the early adopters, the people who get it. They're probably standing in line as well. The early majority are the people, then there's a greater groundswell, and everybody has the latest or maybe the second to the latest iPhone. And I use iPhones just because it's easier to talk about. And then you reach a point where you'd start going down the other side of the curve, where people might adopt the innovation later. And then finally, there are the laggards, the people who say, what do you mean? I don't need a cell phone. What do I need a cell phone for? I have no use for it. Maybe this is your grandparents or even your parents, depending on the age of your parents. I have a neighbor who has a cell phone, hates it because she can't hear it, and usually just leaves it uncharged somewhere else. So that's a laggard. You want to think about this adoption curve when you are working with patients or consumers, because you might be in a different place along the curve than the person you're speaking with. So you have to be cognizant about that. Next slide. So this is our first poll. What we want to know from your perspective as a patient receiving care, what has been your experience of telehealth care delivery? So put some words together. Remember to connect the words with an underscore if it's more than one. And we'll watch them come up. So while we're waiting, it's interesting. Telehealth was something that you didn't hear much about. Maybe you heard about it in rural areas. And then all of a sudden it took a pandemic to really make it the only way to get care if you weren't in the hospital and if you didn't want to get sick. So we're waiting to see what's happening. I hope you're all typing furiously and thinking about this. And if you weren't a patient, maybe you were a participant, for example, a caregiver, or you attended a session with a parent or a grandparent because they couldn't figure out how to get the screens to work. So thinking about that, I've attended a few, and as someone in this field, it was very hard to sit on my hands and bite my tongue.
I will say, Nan, in the times that I have actually been a participant on the side of the telemedicine, it's been a wonderful opportunity to see my provider from a different perspective. I could tell that they were as nervous about using the technology in this new way as I, the patient, was on the other side. So, oh, wow, look at this.
Wow, convenient. It's definitely convenient.
Now people have
Effective.
been disconnected. I see that in there.
Right. And a lot of anxiety, especially among older adults. There's a concept called computer or technology anxiety. They're afraid they're going to do something wrong. They won't look good in front of their provider. Anxiety inducing for sure. I wonder about will my internet last? Will I have enough charge on my phone? Technical difficulties on both ends for sure. If you don't have stable internet or they don't. Miscommunication is big because no one's laying hands on you and they don't see everything. We'll talk about that for sure. Convenient. If this means you don't have to, I'm on a project then in the upper parts of down east Maine, and it's 2 hours to Bangor. And having telehealth would be great, especially for those in the factory, because they don't have to take a whole lot of time off work. They can do it in a lunch hour. Or if you have you're taking someone with some cognitive decline, or maybe a child who's atypical and trying to pack everybody up in the car, telehealth sure makes it easy.
Or even if you're sick and the last thing in the world you feel like doing is having to get in the car and drive to the provider's office or the urgent care center when you don't even want to get dressed, let alone out and drive. So there's many, many advantages.
And let's talk, I mean, we live in Maine. It's not like we're in Boston, so we're not getting on a crowded subway and we're not fighting the traffic on the Mass Pike or 128. But it's still a hassle. So it's much easier and you don't have to worry about fighting for that parking spot. So this is, let's see what else. Some people are not less personal. So I wonder if that's a question with your provider, whether they've actually made enough connection with you over the screen. Sometimes it's hard to build that relationship, especially if you don't have the in-person part. And difficult for low-income patients. We'll talk about that later on around the divide. Finding space to have the appointment can be difficult as well. You might be in an open office, or you might be in an office with thin walls, or you might be at home and you don't want anyone to know.
I see some positive attributes in there as well. So it's good to see the mix.
So at this point, we are going to move. I think we've beaten the horse. We're going to move to breakout session number 1. There's a whole lot of stuff on this screen. As you move into your breakout rooms, consider these words as prompts and talk about the patient perspective for virtual care. What's it like? What would you want to tell someone who is going to be a patient? And how would you engage?
Nan, if I could add,
please,
to speak from your experience of being a patient during this time period too, to speak from the patient perspective. What was it like for you using telehealth and using it suddenly, and have some conversations as patients?
All right, this is Chris again, reminding that our team immersion members will have access to their own team rooms, and hopefully you will navigate there. Lee, if you want to go ahead and open up the breakout rooms and get that started.
Well, actually, I was in a delightful group and heard some interesting experiences. Steve was part of the group, and he actually talked about his experience. He was working in Chicago and was actually a liaison that was helping families and patients visit back and forth. And so he was talking about how tricky it was when you had somebody who was not English speaking and you had to get them connected with the interpreter who had to give directions on how to get onto Zoom. And so really some major challenges, but the rewards that occurred when you were able to make those connections. And one of our other participants was actually working in a psychiatric facility. So they had no visitors, but they didn't have phones either. And so talked about the challenges of trying to use the technology to make the connections, but still maintain patient privacy at the same time, and how that was a challenge. And then also heard about the convenience. One of the participants talked about the fact that she had been exposed. She was working as a nanny and wasn't feeling well and was very concerned that she would expose the infant to an issue. And so actually used telemedicine very successfully to get her needs met. So we had a very interesting group.
I'm seeing in the chat sort of, there's really great aspects of telehealth, but it isn't for everything. I wonder if other people were talking about that as well. You know, some specialties it worked, some it didn't. Some, you know, if the technology was great, fine. If it wasn't, you know, so I'm just seeing a lot of gray and wonderful and not so great.
Yeah. We talked about trying to get an older adult connected to telehealth. And while eventually the telehealth session went well, it was anxiety provoking to do all of the testing to make sure it would connect. I'd also note that I think I read a study somewhere that said that patient experience scores were tied to how well the technology worked. Were correlated. So if the technology didn't work so well, your visit and your satisfaction with the visit, even if you got the issue is resolved, may not have been as good as it might have been.
Do you think we want to move on in just a minute or two?
I was just going to add, I think we all have to recognize that rolling telehealth out in an organized planned way where everybody has received the education and you have IT support to make sure the technology is working is the ideal. And certainly during COVID, as providers were and patients were desperate to make connections and to get needs met, it was far less than ideal circumstances. And that's why we're learning so much. And we have good lessons to share from that.
I'd argue, Sue, it's a little bit like rolling out an EHR, but with the added complexity of isolation and a pandemic.
Well, and that's just a nightmare to think about. I don't even want to think about rolling out an EHR. I've lived through that. So I have to agree.
Okay, so I think we've, what we want to think about really is, I heard a lot about meeting the patient where they are and in my group. And so this is a discussion that I think I'll have Sue lead off with because she's the clinician and I'm the squinty-eyed data geek here to talk about this part.
Well, I think when we talk about from the perspective of the patient, client, consumer, what we have to keep in mind is certainly a variety of things. We have to think about how each culture looks at health, looks at illness, and the connections that are important to them with their provider and how comfortable they feel. So how do we make those connections in such a way that individuals feel comfortable and confident in sharing their information? And we also have to understand that healthcare organizations all have different cultures. And they have some people that are ready users and early adopters, but others who are more reluctant. We also see patient-client characteristics. We've talked about. I apologize. That's my phone in the background. We have age, we know, is an issue, and how confident you are in your ability to use the technology. And you can have somebody 75 who's very comfortable with the technology and somebody who's 50 who is not. So we have to consider that. Are you rural? Do you have access? Do you have the ability to have privacy in your home? What kind of technology is available? We know that data plans have their limitations, and despite the fact that we see ongoing commercials about 5G technology, it's expensive and not available necessarily to everybody. And then there's disparities of all kinds. There's disparities in insurance coverage, in workforce shortages. So where are the providers available, and are you getting coverage from a non-traditional provider? There's just all kinds of disparity in the environment. And so we have to look at all of that as both barriers and opportunities for patients and clients. So we've got a lot to learn from the experiences that we're all having. And we know that certainly vendors are anxious to make the connections easy, because now that consumers have had a taste of the convenience of telehealth, they're not anxious to get rid of it. Doesn't mean it's right for everybody and every situation, but I think we have turned a corner in healthcare. And so we need to learn to do a better job in our provision of telemedicine.
Right, Sue, and I think it's both an issue on the provider side and the vendor side to make it easier for people to connect. Going back to my EHR thing, it should be intuitive, just like my phone. Mm-hmm. Isn't always. So this slide is some results from a very tiny study through the Geriatric Workforce Enhancement Program. And of the 40 people who responded, we asked how they used their tablets. And you'll notice that a lot of it was to look up information, because it's really easy to go to Dr. Google on there and look up something. Whether the information is right and you believe it, we don't know. Very few, half of those people also used their tablets for telemedicine and a patient portal, less so for any kind of tracking. Certainly I don't think they had Map My Run or MyFitnessPal on their app, on their tablet. But I think the more interesting piece is the other graph in terms of how many apps they actually used at one time. So 9 people, as we can see, used the app for one activity, and another 9 people used it for 2 activities. Less than that used it for 3 or 4. So this is my device for looking up health information, or this is my device for telemedicine. I think if we had asked if they use their device for talking to friends and family or texting with them, I think it would be even higher. But it might be only a single use thing. I don't know if any of you have had to try to convince your parent or probably your grandparent to say, you can use it for something else at the same time. You can talk on the phone and look at your calendar as well. That seems to not make, that seems to be like magic to them. Not quite comprehensible. This slide, as Sue mentioned, she talked about the patient and the provider and the practice. And I'm calling this the ecosystem, because you have a patient and we can talk about all the characteristics of the patient. And we can talk about all of the characteristics of the provider. And to some extent, we can talk about the encounter, the interaction between the patient and the provider. But there's another layer around that, which is the practice or the department in the institution. For those who have been in the workplace, sometimes you might come up with a great idea and management just squashes it. So that might not be a place where it's possible to bring on telehealth and to get it to spread. There are also financial issues. If you bring in telehealth, you have to bring in equipment. You might have to bring in someone who's responsible for the care and feeding of that equipment. And you might have to bring in someone who's responsible for scheduling all the visits. And it's not the cost savings that you might think. And we don't know yet whether they're the same outcomes and the same quality of care that happens over telehealth for a long period of time compared to in person. So those are things to think about from a financial and a reimbursement perspective. There's also a regulatory perspective. Can I practice across state lines? If I'm licensed in Maine, could I practice in Massachusetts to make telehealth cost effective? Can I do that? Now, if you work for the VA, that's not a problem because it's all one. Communication is a big deal. If you're working alone at your dining room table, you don't have the opportunity to bump into someone at the copy machine to say, hey, I'm having trouble with someone, or I'm having trouble with the technology. How did you solve it? The way that you get information is a lot harder than if you happen to be together in person. So I think there are advantages and disadvantages to this. Next slide. We talked earlier about broadband access, and it's not just patient, it's also provider, and it's not just rural, it's also urban. This map is a picture of access to broadband that's fast with a good resolution so that you can do those telehealth visits and get an image of the patient or the wound, or a part of the patient, the wound, to see how it is. You'll notice that parts of inner cities also have difficulty with broadband. I don't know if you've ever been in your house and you have to go to another room to get better cell phone coverage, for example. This is something that really has to be fixed if we want to make telehealth available to all and to decrease the disparities in access, both for patient and provider. And I believe this is falling under infrastructure. So the next slide. We've talked about the digital divide, and it's an uneven distribution and differences in access and usage. So thinking about if you're in a rural area, Sue talked about this in the beginning, that if you're in a rural area, how you access care or when you access care is very different than perhaps an urban setting. It might be that your provider is someone that you know, someone that you see at church every week, someone that you run into in the Walmart.
I apologize. I just wanted to say that I think there's a lot of concern in the literature that telehealth can either improve the digital divide by providing services, healthcare services to those who don't have current access, but at the same time, it can make the digital divide worse. Because as more individuals continue to use telehealth in order to access care, it just continues to make those inequities between those who have the resources available to take advantage of this opportunity and those that do not. And so I think we need to continue to work with legislators and communities to see how we can ensure that everyone in the community has opportunity to take advantage of the technology.
Right. And this is a good time to plug the National Digital Equity Center, because they offer low-cost tablets and hotspots to those in need. I think it's 65 and over, Shelley? Does that sound right? Yeah.
Yeah.
And this slide shows you the inequities based on income. If you look at smartphone usage, for the dark blue are those who earn less than $30,000 a year. And many have smartphones. That number has increased a little bit in 2020. Desktop and laptop computers have as well. Broadband, not so much. And very few really have all of the bells and whistles compared to those with a higher income, which of course makes sense because it's a data plan and it will cost you.
Dan, could I say something about this while we're in that spot there? This is Dr. Victoria Timmy. I teach for Unicom. Hi. And I take care of a lot of older adults, and I teach in geriatrics, and I have a private practice. And the part that I've been noticing in terms of comfort with usage is that people who are aging in place, who have a change in function to the point that it's not really age dependent, it's function dependent. And we as clinicians have to check in with people to assess their function a little bit more often. As you know, the instrumental activities of daily living ask the question about whether you can use the telephone. And I tell all my students, if anybody wants to become famous, because I'm too tired out to take this on, but that needs to be redesigned because it's not a telephone that we're really inquiring about. We're inquiring about communication through technology, which, as you mentioned, is how do you use your smartphone? How do you use your iPad? How do you use your desktop? And how often is it crashing? How often is someone taking advantage of you? And so I think in this realm, as we move into portals and telehealth, we have to be very sensitive and responsible as clinicians to ask the questions ahead of time so that we assess functional ability of this human being who we're trying to communicate with in a new platform. So
I would agree with you. My parents are in a nursing home, and they had a telehealth phone visit. But it was interesting because the MA never bothered to look at the chart for my mother. My mother is paralyzed. They were asking questions about driving. She's got cognitive decline. They were asking her when she falls asleep. They don't remember. So I think that there's a part that has to happen up front. I almost want to hire an anthropologist or a sociologist to do some work to say, what are the questions that you should ask? And to ask them more slowly over a virtual platform compared to in person. Understand it, ask the question, change it up based on what you see. And I think it's also dependent on the vendors to provide better speakers for those who are hard of hearing, better screens for those who have visual impairments, and for those who have any kind of neurological tremors. It's really difficult for them to hold a tablet or a phone and to hit the right button.
We have a really interesting question here that is a little bit different from talking about aging populations, and from Belle, who says, I'm curious to your thoughts, especially since you're discussing the equity component of telehealth, about the topic of telehealth giving us more access to more diverse providers in states like Maine. And Belle, if you would want to unmute for a second, if I didn't quite ask that question correctly.
Sure, and I don't mean to take us off topic if this is a component of the programming, but research shows that there are only about 5% of providers of color, specifically in the mental health field, upon getting licensed after graduation. I will join those ranks. And Maine, as we all know, or maybe not all of us know, I don't want to make an assumption, is the whitest state in the country. As we've seen with the rise of COVID and with the Black Lives Matter movement and other November is the Social Determinants of Health Month here at UNE, just as we think about telehealth and giving more access to folks with all of their health disparities, and giving them more access to providers who may have not been as accessible when we were in person. I'm just curious of telehealth as being one avenue, channel. I'm not sure of the right term, but what are folks' thoughts around that?
I think I'd like to, after you talk, Sue, I think that would be a great topic for the panel to discuss.
I agree. I think the joy, the blessing that we have with telehealth is that it does provide an opportunity to make connections from a great distance. It doesn't have to be from within this state, but I would like to hear from the providers that are going to be on a panel that may be able to shed further light on that conversation as well.
Okay, good. All right. So are we moving directly to providers?
Yes, I think we
should. All right. With that wonderful segue, we're going to move directly to the providers. You can read all about them here. Dr. Shane Champimol, I always butcher that. I'm sorry, Shane. He's a physical therapist working for the VA and lives right here in Maine. Kristen is at Tri-County Mental Health and has been providing services and leads a team of mental health practitioners. And Brendan Past is a resident in the family medicine at Maine Medical Center, and they've all have experience with telehealth. So I'm going to turn it over to them and let them talk about it. Shane, do you want to go first? We'll do it.
Sure. So I'll start. My name is Shane. I'm a physical therapist. I'm a neurological certified specialist. I work for the Washington, D.C. VA. My position is funded by the Office of Rural Health, and I live here in Maine. I also do per diem in New England Rehab Hospital, just to kind of keep my in-person, hands-on stuff. But otherwise, I'm full telehealth. So kind of getting into a little bit of the question and my thoughts, what I've found over the last several years, and I've been doing telehealth for about 7 years. So even pre-pandemic, and really just when pandemic came around, it just upticked, like that graph in the beginning, just, huge uptick and surge. But as far as for specialty care specifically, and I work with veterans with ALS solely at this point. And I work with the multidisciplinary team, and I help kind of spearhead the tele-ALS component. And we do full comprehensive tele-ALS, multidisciplinary. We have a neurologist, a nurse practitioner, nutritionist, occupational therapist, physical therapist, speech language pathologist, dietitian, GI nurse, mental health, social work, all within our clinic. And we coordinate, and I help coordinate making sure that we get all of that, including respiratory therapy. And we do remote patient monitoring. So for specifically for specialty care, telehealth has been a total game changer. In DC, we are the only multi-D ALS team within our VISN, which is our region, which includes about 6 other facilities. So we get a lot of consults and referrals from other facilities, and that's really massive. We do prefer to see our evaluations in person, but during the pandemic, our neurologist has pretty much called everything off. Once DC went up in higher risk, and ALS patients, if you're familiar, the respiratory status and risk for any respiratory infection, it can likely be fatal. So it's been a big game changer. And I think that's true for all specialty care, where you're really looking at providing access where there potentially would have been none otherwise. And that's the big, that big 0 to 1, I think is huge. I know that a lot of people have talked and kind of shared thoughts of, it's not the same as in person. It feels a little bit disconnected. Some have said that they felt like it's hard to show empathy. But when you're talking about somebody who potentially needs, a handicap accessible van to get to where they're going, if they're going long distances. And for me in the city, it sounds a little, counterintuitive, but I like to call it urban rurality, where someone who is 10 miles away can still take them 2 hours to get to the facility. They might not be traveling very far distances, but between, a midday appointment in a big city like that, you can still be really disparate from your facility. So telehealth in that regard has, overcome a lot of big hurdles. Just kind of getting back to that previous topic. So happy to hear the other panelists' thoughts.
Go ahead, Kristen, you're next.
Hi, I'm Kristen Gingrich. I oversee a behavioral health home program, which is pretty much just a fancy word for case management, as well as our outpatient services out of our Bridgeton office through Tri-County Mental Health. We're a community mental health agency. We went telehealth overnight. Telehealth services were not really a thing in our agency pre-COVID, and we really had to kind of learn it really quickly. I shared earlier that I came into my position on March 1st, 2020. I got my promotion right before we got sent home. So not only was I in a new position, but I was also learning how to be a supervisor to a brand new team. And one of those things that we really had to learn, and I think even working with clients, is the idea of positive intent. When communicating via email and things like that, with especially like working as a team and working with other providers. Our behavioral health home is consisted of case managers, peer workers, a nurse. We consistently work with PCPs and psychiatrists and cardiologists and just all different providers under the sun, and really needing to understand that meeting face-to-face, and when you meet via Zoom, you are missing some of those kind of nonverbals. So we had to learn really quickly how to still pull together as a team, which was amazing to watch my team do. And working in the area that I do, it's rural Maine. There's a small town, but we go out rural real fast. And we have several offices throughout our whole agency that lost several staff during the pandemic. And pre-telehealth, their staff would have had caseloads of 50 clients, 60 clients as a case manager, because we just can't close out those services. But because of telehealth, I actually have some staff in my office who are seeing Rumford Farmington clients, which is a good 2 hours away from us, as case management assisting them so that their staff aren't carrying caseloads of 60 people. It's been really helpful in a lot of ways. It's very much also had its limitations. Living in rural Maine, the internet goes out real quick. We have a high, low socioeconomic status of a lot of our clients, so a lot of them don't have smartphones, or if they do, they're not great. The first several weeks of the pandemic, we're troubleshooting with our older adults and even some of our younger adults who just never have had access, troubleshooting how to start Zoom and how to really connect on the phone. We've seen clients where for the entire pandemic, we would talk to them for a half hour every week because engaging them telehealth was difficult. And then we had clients, like I can speak specifically for one of mine, that it was the most open and vulnerable they have been in the last 3 years that I've worked with them, because it created a little bit of a separation, and it didn't feel as vulnerable to be vulnerable. But yeah, it's definitely, it has its ups and downs. But we had to look and overcome a lot of barriers. And I felt that for a lot of the clients that we work with, we have a high no-show rate, a high, like, people forgetting about their appointments, not coming in. And telehealth has provided, even now as we're back in the office full time. We are still utilizing telehealth, but sometimes it's like, oh crap, I forgot about my appointment. Can I just hop on Zoom? Yeah, let's still meet. So we still have that ability. Whereas before, if they just didn't come into the office, they just didn't have an appointment until the next week. Whereas now we can break down some of those barriers in that capacity.
Thank you, Kristen. Brendan, you're up.
Hey, everybody. So I'm Brendan. I'm a third-year family medicine resident at Maine Med here. So I had the benefit of, starting residency just before COVID started. So while about halfway through my first year, while struggling to, learn how to be a doctor, also was learning how to deal with the system, while also struggling to deal with a pandemic and going largely virtual for a time in the middle of that at once. So it was sort of a great trifecta of things. So some of the stuff that's really struck with me, and like it's both struck me and stuck with me since then, is just the both the amount of barriers that are sort of put up by some of this, but also barriers that we're able to break through. Some of the stuff that's come up that surprised me is just the sheer amount of preparation that goes into something when you're just sitting in an office. You think it would be much easier to get everything ready, but the amount of stuff that I have to make sure is prepared, whether making sure myself am prepared, I have my software working, the camera actually works. I've been surprised by blown cameras in my clinic office several times now, where I just have to either use a phone or run to another computer, make sure the patient actually has the software working, make sure they know what a telehealth appointment is, because I've had people try to set up the email and they say, I don't have email. What is that? I signed up for telehealth. I thought it's telephone health. And just trying to sort of prepare folks for that along the way as well. So it's an interesting learning curve on both sides. But in terms of the barriers that I've been able to remove, like I have one patient who moved up here to be closer to family from pretty far away. And then when COVID started, I'd just seen them for their first visit a month or so before COVID. And they came up here, they were isolated, couldn't really drive on their own, but luckily they were living with their family. However, when COVID hit, their family did not take this very well and immediately put themselves into their homemade bunker, where they planned to be locked up for at least 2 years with enough supplies to last them through there. So this patient who came up specifically to be with family who would be their transportation and support was now literally stuck outside of their bunker in a separate house on the property and had no way to get to appointments, no way to get to the store, no way to really do anything. Needless to say, they were struggling with mental health concerns for a decent amount of time. But we were able to work around and basically teach them over the phone how to use telehealth, connect them with our interdisciplinary care management team. And this is one patient where it was, I honestly feel like I've had the biggest, it's had the biggest difference of being able to do telehealth, because she literally sent a message one day saying that we literally saved her life from the depression and isolation and just everything that was going on with her. So cases like that, where we've been able to remove barriers to care through this telehealth, is just huge. And I'm very, very thankful that we've been able to do that. And I push telehealth as much as I can with my patients, especially for mental health concerns, anything like that, where I don't need to focus as much on the physical exam. One of the last things that I wanted to sort of dive into, Bill, I don't know if you can clarify in the chat about what you brought up. Do you mean diversity of like patients we work with, diversity of the providers we're able to work with, as in like diversity of careers, or like a diversity of backgrounds?
Sure, Brandon, thank you so much for asking for clarification. So for example, a really good friend of mine identifies as LGBTQAI+, and when she was coming out to her family, she is also AAPI, Asian American Pacific Islander. She really faced significant hurdles and wanted to find a counselor who was culturally humble and competent and supportive of supporting her. And so, you know, she lived in a large like metropolitan community. And so when she went to Psychology Today, she was able to, you know, check off someone that understood her faith background, and also her ethnicity, and, you know, also that she was coming from, you know, the LGBTQ community. And so when she moved to Maine and we met in the nonprofit background that I came from, she asked me point blank what it was like growing up being Asian and in Maine. And we know as healthcare students and providers that rural health in Maine is only 30 minutes outside of Portland. And so I struggled to answer that question because I know what I know, and I'm from Maine. So, you know, I grew up from Maine. And I thought about if I was in the provider chair someday helping someone like myself, you know, what would be the centering questions that I would ask them, and in that first initial intake, and how would I want to create psychological safety. And so with the advent, I guess, of telehealth, you know, there are a lot more options, I guess. And so if I was seeking, not that a person who is an ally can't be competently cautious with their patient and create psychological safety, but if I wanted to see a provider of color, I could seek that out via telehealth. And so I guess my question for the panel earlier was, when we're building the avenues and creating psychological safety for our clients and our patients, how do we build that factor into telehealth in a state like Maine that might not be as diverse as, say, New York or California? Does that help?
Definitely. That's very helpful. And thanks for clarifying all of that. I think from my personal experience as a family provider, we are, at least in the physician realm, limited in the state of Maine for telehealth, just because of what all of the, you know, licensing issues we have, where I have to, as part of the preparation I mentioned earlier, I actually have to specify, like, find out exactly where people are and what state they're in. Because if they're out of state and I prescribe medications, or if I make a recommendation, something bad happens, my license does not protect me from getting sued in any other state, even if they normally live here and they're just across the border in New Hampshire. Well, New Hampshire, sometimes we have some crossover. Let's say Vermont. So if I recommend something to someone and they do that in Vermont and have a horrible side effect, I will have no protection from my license, because I was technically practicing out of state lines, even if I'm still sitting in my office in Portland. So where telehealth, in theory, at least in my field, will have, where we've sort of removed a lot of those borders between states, and helping increase by a huge amount the amount of providers that we'd have the option to reach out to. It's one of those things where legally we're still working on the system, make it, you know, make it legal, make sure that we can be protected by law when we are taking care of patients over there. So it's more of a, at least in my experience, in theory, protected more than practice. But that may also vary depending on the specialty. So I'd be interested to hear, Shane and Kristen, what your thoughts are.
Oh, I definitely, back at the beginning of the pandemic, had an individual who was looking for someone who was looking for more specialty care. And the person that we found was an out-of-state provider who just happened to be licensed in Maine. Luckily, the client was open to working with a provider via telehealth. But I think that's one of the things that telehealth is allowing is for individuals to be licensed in multiple states. I have a friend who is a person of color who lives in Arizona, practices mental health treatment in Arizona, Minnesota, New Jersey, and I think Virginia, because she realized like that's places that she has been. And so she realized like the lack of providers in those areas for people of color, and that when she would search that it was very white dominated. And that's something that I have started actually seeing in things like Psychology Today, seeing more providers popping up who are out of state, that allows individuals to be more selective about who they want to work with, and find individuals who have and are trained in different backgrounds. Whether it's one of the things that we're starting to see is, even this healthcare, even working specifically with healthcare workers. I know like we're starting to see providers pop up across the country who are specifically now training themselves to work with COVID healthcare workers. And again, being able to look at that and being able to choose someone who is more specific than you might have in your area that we never had before. And I think that is a huge benefit. And I think we're going to see more of that because every day we're seeing more and more individuals get licensed in different states. I have several friends who just in this area, they're licensed in Maine, New Hampshire, and Massachusetts because their specialty allows them to be. And it's needed in other areas.
I would say on my end, it's a little different. Since I'm in the VA, we're fortunate in that the federal government just allows us to treat across the country. There was a time where there was a little bit of concern of, reciprocity and things like that. But fortunately, we're able to at this point, we're able to, I can treat anybody anywhere, a veteran in any location. And I believe that actually extends outside of the country as well. So for me, it's a little different. I would say kind of getting to some of that cultural competency and, for me being a physical therapist and having to do obviously a lot less hands-on, I do a lot more talking, certainly. And I think one thing, and I've talked to this about other, just as an aside to other PT students, being able to talk well, and specifically, I've done a fair amount of training in motivational interviewing, which I feel like has really helped my practice, particularly in telehealth. Being able to, use empathetic reflections and get people talking. I also work with ALS, so I do a lot of talking about, dealing with the loss of function, physical mobility and those types of things. There's a lot of, emotional and psychological components that go along to that while I'm, actually in my session trying to maybe train somebody to do a transfer or something, or have them work on their balance, which has been, declining and which will continue to decline. So I would say, just to add on to that, I think that talk ability, and I want to say talk therapy, but, that ability to interact with your patient on a more human level outside of just a clinical basis, I think is really important, particularly for someone like me who obviously would be much more manual in person.
And Shelly, just to talk about your question briefly. So you mentioned interdisciplinary or multidisciplinary teamwork.
Oh, yeah.
For me in particular, would be almost impossible to function without my team that I work with in the office. because you can imagine where I do primarily in-person care, but with telehealth mixed in as much as I can, especially for those who specifically ask for it. If I'm taking care of a patient, I'm in a 20-minute appointment and the next visit starts, I need to have, my team will reach out, often without me even asking. They will call that patient, make sure they are all set up, they have internet access. If they don't know how to log in, they will actually walk them through the steps of how to log on to Zoom, which we're now using through our EHR, which I think is great. And they will set that up. I can have my triage nurses jump on as well to help me out as like for support if there's something where I'm not able to get onto the line just in time. Or we even use my chart on Epic, which is the instant like email messaging system as well that they'll get sent to me, but my team of my medical assistants, LPNs, and RNs will all be able to look at that as well if I'm not able to get it first thing and page one of us or call us. So while it would be possible for me to eventually get to all of that, I'd be running hours behind in a 4-hour session, which would be frowned upon. So I really rely on my team heavily for that.
Thank you, Brendan. I'm wondering if others could briefly talk about that collaboration that they see happening with telehealth, and then we're going to go to breakout sessions.
Yeah, I mean, over here, again, in case management, we're working with a whole slew of providers, whether it's in medical field or it's just doing IEPs at school. And we are working with an HCT provider, a human community treatment provider. And it's definitely, we've had to get creative through the pandemic, working with individuals, because we were doing like kind of Zoom meetings with schools every once in a while. But really kind of zooming in and working with BHPs and kind of saying, okay, what are we doing here, has been super helpful. I think that it's also created the ability to connect more often. Even though we could connect via phone, it was more like, let's set up a meeting to meet face to face, versus now it's more, now we can meet quicker because now it's regularly more accessible to meet via Zoom, which sometimes we talk about it now and it's like, why have we not done this before? Why were we driving an hour and a half to like on the opposite side of Lewiston and wasting all of that time? We could have just done it and had that. And we know why we did it. The face-to-face has been great, but there's definitely been some saving graces. I think we've really worked with developing, like, even as our team, like, again, our BHH team consists of a family peer worker, a peer worker, case managers, as well as a nurse. And we have really kind of rallied together during the last year. Again, we're back in the office now, but previously we, like, they would specifically make phone calls every week. Every case manager had a phone call with a nurse and a phone call with a peer to make sure that they were staying connected. With our clinicians, we were no longer, one of the things we drive at our agency is that HHCs work very closely with the clinicians if they share clients. They also were having weekly meetings, consistently emailing and using those. And I fell back on the idea of positive intent and always remembering, like, when you read something, read it monotone, because we can so quickly lose ourselves in that. And that's one way to kind of break down that interdisciplinary piece, as well as break down a team really quick, is all it takes is one misunderstanding.
So we're eager to get to breakouts. Shane, do you want to just have a quick word, and then Chris is going to take us to the breakout sessions?
I would just echo, for me and my experience with the interdisciplinary team, we collaborate with everything. We're always talking to each other pretty much every day. When we have ALS clinic, we're coordinating folks in the background, clinicians hopping in and out of video so that it's just a steady stream for the patient, as if they were in the room. Clinicians are hopping in and out of their video. And then at the end, we all essentially round on each patient. And then, from those, we're chatting back and forth, email, Skype, and kind of managing every case individually like that with the team.
Well, thank you, panelists. That was amazing. Thank you so much. And we're going to try again we to get us all into breakout sessions. And we really want you to think about the panel discussion and about skills and resources that are needed as providers working with patients and teams. What are the strengths and what are the barriers? So shall we go into the breakout rooms?
So I think for me, obviously there was a big learning curve with being a physical therapist, being a lot more hands-on. What I found I've had to really rely on is having zero qualms about asking for help from either the patient or from a caregiver, and really, leaning on a caregiver or family member for help either with technology or with, a lot of times moving the camera and things like that. So I've worked with other students that are always very timid to ask someone just to move the camera so that they can see, a specific movement or something like that. And because they feel like they're just not comfortable with it, or they're asking more of a patient to do something, and it adds time, which I think is maybe the other thing that makes a clinician a little bit more timid. So certainly for telehealth, I would say I've gotten used to maybe not getting as many things done, as many specific exercises done in a 30-minute session, but really kind of honing in, making sure that I've got, that they understand the movement, they understand what they need to do over the, the period between our sessions. And what I've also noticed, at least in my own practice, with telehealth being more, so accessible, and I'm not full-time, just patients back to back to back. I have a pretty large admin component. So I'm able to actually see, and I do my own scheduling. So I really like in telehealth that I've been able to do more frequent touch points and smaller touch points without added burden of travel to the patient. So, I can see somebody twice a week and they're not worried about having to take off work. They're not worried about having to get to the clinic and still do a shorter session of maybe only 30 minutes, but really focusing on 2 or 3 exercises and not having any qualm about just going, pretty quickly and doing and more frequently. And that's really been nice, particularly for ALS, which is in neurodegenerative diseases where things are progressing, can, be either slow or quick. So not having any issues of, how long in between, because normally we'd see them every 3 months, but I tend to actually see them closer to, once a month or every other week, or once a week if I'm actually actively doing therapy with them. So that's been a nice piece and a benefit of being able to change over into telehealth.
Yeah, I agree. Good point. So I think this is the point where we thank our fabulous panelists for making it very real. I could, close my eyes and imagine I was there in their chair. And I think that they really made some of the reading really come alive, the experience. So thank you.
And thank you to our wonderful hosts too, to Nan and Susan. Shane, were you saying something?
I was just saying thanks for having me.
Our pleasure. Absolute pleasure. And thank you to everyone who stayed till 7:33 on a Monday night. Now go have your dinner and whatever beverage you choose and put your feet up and read a novel, watch TV, or go to sleep. Your choice. Good night, everybody.
Good night.
Good night.